So what's about HER2 positive breast cancer in the last 3 years, I would say, because we had really the opportunity to change the treatment landscape in this specific disease. Those are my disclosures. So let's start to present the treatment algorithm in this disease. So we had a lot of new practice-changing data in the field of metastatic breast cancer, HER2 positive. But if we have to summarize what is available until a few weeks ago, we had as a first line, of course, the opportunity to treat patients with taxane, trastuzumab, and pertuzumab, but that is still the standard of care. In the second line setting, because actually we don't have any FDA or EMA approval for trastuzumab deruxtecan, we have still the opportunity to treat the patients with T-DM1. And then in the third line, we have a lot of opportunities: tucatinib, capecitabine, and trastuzumab, trastuzumab deruxtecan, lapatinib and trastuzumab, capecitabine and daratinib, lapatinib, trastuzumab, tucatinib, trastuzumab plus chemotherapy, and margetuximab plus chemotherapy. We should add also the opportunity to use pyrotinib that is only available in China. What's about ESMO? So what we did following the presentation of the DESTINY-03 data during the ESMO 2021 meeting, we completely changed the treatment landscape for HER2 positive disease. So in case you have an HER2 positive breast cancer stage 4, the first line treatment is the combination of a taxane plus pertuzumab and trastuzumab. So the data of the Cleopatra trial are still representing the standard of care in this patient population. What's about the second line setting? In the second line setting, the new standard of care that has been suggested by the European Society for Medical Oncology is trastuzumab deruxtecan for patients with known, unknown, or stable brain mets, because in the DESTINY-3, there was also the opportunity to include patients with stable brain mets. And in case of active brain mets, the suggestion that can be contested, we can discuss about this, was tucatinib, capecitabine, and trastuzumab, or trastuzumab deruxtecan. And I will show to you later some data that have been presented in the meeting of San Antonio. What's about the following lines of treatment? In the third line setting, of course, we have still the opportunity to use tucatinib, capecitabine, and trastuzumab, or trastuzumab deruxtecan, or T-DM1. And following progression to those treatments, we have lapatinib, trastuzumab chemotherapy, margetuximab chemotherapy, neratinib chemotherapy. Don't forget that for patients with active brain mets, the only treatment approved is the combination of tucatinib, capecitabine, and trastuzumab. Let's go now in the details of those recommendations. So first line therapy is the combination of pertuzumab, trastuzumab, and taxanes. Why? Because we have still the data of the Cleopatra trial, with the final update published in the Lancet Oncology, and with 8 years follow-up, we have still patients that are alive after 8 years. 37% of the patients are alive in docetaxel pertuzumab trastuzumab arm, and 23% are alive in placebo trastuzumab and docetaxel arm. And there is still a benefit in progression-free survival, with 16.3% of patients not progressing with a median of 6.3 months, versus 10% in the arm that was placebo. Don't forget that you can combine pertuzumab and trastuzumab also with paclitaxel. And there was exactly the Peruse study that explored the activity of pertuzumab, trastuzumab, both in combination with paclitaxel or with nab-paclitaxel, confirming finally that there is absolutely no difference. Another study that has been completed recently was the Sofia Trial, at least the progression-free survival analysis. The Sofia Trial explored the combination of margetuximab plus chemotherapy versus trastuzumab plus chemotherapy in a patient population that progressed to the combination of pertuzumab, trastuzumab, and taxanes, and to TDM1 also. And there was a marginal benefit of the combination with margetuximab, so we are not so sure that here we can, of course, consider this as a standard of care. If you remember, during the ASCO meeting this year, we had the final overall survival analysis, and the addition of margetuximab to chemotherapy did not improve overall survival. Many new tyrosine kinase inhibitors are under development, but the only two that got approval for HER2-positive disease have been tucatinib, at least in the Western world, and pyrotinib, that I believe is a very interesting tyrosine kinase inhibitor, but pyrotinib is approved only in Asia. So here we have the new third-line therapies for HER2-positive metastatic breast cancer. So in the first line, we have pertuzumab, trastuzumab, docetaxel, in which we have an overall survival benefit finally of 57 months. In the second line, we don't have trastuzumab deruxtecan approved. That's why I reported TDM1. We have TDM1 with 29 months of overall survival. And then in the third line, this is the median overall survival. For neratinib plus capecitabine is finally 23 months. For tucatinib, trastuzumab, and capecitabine is 24 months. For TDM1 is 6.2 months. And finally, 18 months for the margetuximab trial. If we just look at the data of the DESTINY-01, the median overall survival of trastuzumab deruxtecan in the second line in the context of the DESTINY-01 is 29 months. So you can understand that it's really the new second line treatment. Following ESMO 2021, and according to the ESMO clinical practice guidelines, the new second line treatment that is absolutely recommended by ESMO should be trastuzumab deruxtecan. And in the third line, we gave exactly the same option to use tucatinib, trastuzumab, capecitabine, or TDM1, that in our opinion was equivalent. And then in the fifth line or the fourth line setting, we have a margetuximab chemotherapy, neratinib, capecitabine, or trastuzumab, lapatinib, or other chemotherapies. When considering active brain mets, you should consider every time the combination of tucatinib, trastuzumab, capecitabine, or trastuzumab deruxtecan, or TDM1. Why supporting this recommendation? These are the data of the DESTINY-03 prospective randomized trial comparing trastuzumab deruxtecan versus TDM1. The primary endpoint was progression-free survival. The secondary endpoint was overall survival. Secondary endpoint included also overall response rate and duration of response. In the analysis presented a few weeks ago during the San Antonio meeting, we had the updated data on progression-free survival, and we had a snapshot of data in patients with brain mets. Don't forget that in the DESTINY-3, active brain mets were not eligible to the study. So here we have patients with history of brain mets. I mean patients who had previous treatment with brain mets, and patients with brain mets at baseline that have been pre-treated. It's a huge number of patients, finally, because here we have something like 100 patients with brain mets that have been included in the trastuzumab deruxtecan arm. So half of the patients in the DESTINY-3 that received trastuzumab deruxtecan had brain mets, not active, but brain mets. In the final analysis of the DESTINY-3, the use of trastuzumab deruxtecan dramatically improved progression-free survival with the NADSA ratio of 0.28. There is a trend also of overall survival that will be better respect to the DESTINY-1. So 84 of patients treatment with trastuzumab deruxtecan had progressive disease, and 155 of patients receiving T-DM1 had progressive disease. What's about the progression-free survival in the key subgroups? All subgroups had benefit from trastuzumab deruxtecan, independently of hormone receptor status, of prior treatment with pertuzumab, of presence or not of visceral disease, of prior line of treatments, and independently of brain mets. So this is an important information. What's about the response rate with trastuzumab deruxtecan? The median response rate in all patients was 79.7%. It's an impressive response rate. Why it's impressive? Because you would agree with me that if we consider selected patients with the novo-metastatic disease, maybe with oligometastatic disease, trastuzumab deruxtecan may really offer the opportunity to cure those patients. So in my opinion, the impressive response rate of this antibody drug conjugated is outstanding in the context of HER2-positive disease. When we consider specific response rate according to subgroups, there is no difference, finally, according to prior pertuzumab treatment, according to visceral disease, prior line of treatments, or patients with brain mets. Because if you can see of here that the response in patients with brain mets is the same. What's about progression-free survival and Kaplan-Meier curves for patients with and without brain mets? Here we have exactly the same data. If you look at the brain mets patients, the median progression-free survival was 3 months with T-DM1 versus 15 months in patients with trastuzumab deruxtecan. So there was a statistically significant and clinically meaningful benefit in terms of progression-free survival. And looking at response, finally, here I am discussing about response on the brain mets. Some response had been observed also in patients with brain mets. You know that during the San Antonio meeting, we had some data on the Sofia trial exploring the activity of trastuzumab deruxtecan in patients with active brain mets, and was observed the potential activity in that patient population. So looking at the intracranial response with trastuzumab deruxtecan in patients with baseline brain mets, here we have 27% of complete response and 36% of partial response. It's a subgroup analysis. It's a proof of concept analysis, but I believe it's an important information. Here, we can really understand that trastuzumab deruxtecan can be also active in brain mets, and the intracranial response is confirming this. In the overall and exposure-adjusted safety summary, the median treatment duration was 14 months. And if we look at the safety data, the most common toxicity of trastuzumab deruxtecan was hematological toxicity and gastrointestinal toxicity. Looking at the data with ILD, inflammatory lung disease, in the DESTINY-03, with the longer follow-up, no grade 4 or 5 toxicity was observed, and the incidence of grade 3 ILD was 0.8% in the overall population, 0.7% in the Asian subgroup, and 0.9% in the non-Asian subgroup. The information from this analysis is that once we improve education of patients and we better know how to manage ILD, if we recognize it, we can treat it, and we don't, of course, have the risk of a fatal ILD. You know very well that according to the Destiny-03, we have a new standard of care. So in the second-line setting, the optimal treatment should be considered trastuzumab deruxtecan. I would like to announce that in a few weeks will be published also the New England Journal of Medicine paper, and it is expected to have very soon the FDA approval. Looking at the data regarding to the response rate of the CNS meds, we have a 27% intracranial complete response. That is, of course, a very, very important information. And don't forget that it is important to manage ILD. And the management of ILD is, first of all, to recognize it and then to give an appropriate treatment. What's about other agents available for HER2-positive disease? During the ESMO meeting 2021, Christina Sauer presented the data of the TULIP trial, prospective randomized trial, comparing trastuzumab duocarmazine versus physician choice treatment. In the physician choice treatment, we had lapatinib, capecitabine, trastuzumab capecitabine, trastuzumab vinorelbine, and trastuzumab eribulin. The primary endpoint was progression-free survival. The secondary endpoint was investigator-assessed PFS, overall survival, and response rate. There is an improvement in progression-free survival, but you would agree with me that if you compare with trastuzumab deruxtecan, is a marginal improvement. We have an improvement of PFS from 4.9 months to 7 months. That is statistically significant, but is not clinically meaningful. In my opinion, trastuzumab duocarmazine is a very important toxicity. Finally, we had 21% of patients with grade 3 toxicity, included ocular toxicity and ILD pneumonitis. Don't forget that 6 patients died in the TULIP-3 for ILD that maybe was not recognized or was not managed. I don't believe trastuzumab duocarmazine will be included in the treatment algorithm of HER2-positive disease. Recently, we published on the Annals of Oncology the final overall survival analysis of their HER2-CLIMB study. Their HER2-CLIMB explored the activity of tucatinib, capecitabine, and trastuzumab versus placebo, capecitabine, and trastuzumab in patients who received a previous treatment with pertuzumab and trastuzumab and with T-DM1. And in the clinical trial, have been eligible patients with untreated or active brain mets. Those were the characteristics of the patients. 410 patients received tucatinib, trastuzumab, and capecitabine, and 202 patients received placebo, trastuzumab, and capecitabine. You can see over here that in a two-club trial, we have 40% of patients with treated and stable brain mets, and 22% of the patients with active brain mets, including 22% untreated and 37% treated and progressive. In the final analysis of the study, there was a benefit in progression-free survival, improving median progression-free survival from 5.6% from 5.6 months to 7.8 months with tucatinib, trastuzumab, and capecitabine, but there was an overall survival benefit, improving overall survival from 17 months to 21 months in the third-line setting. So I believe really this is an important result. And when we consider progression-free survival in patients with brain mets, we have clearly an improvement in progression-free survival, a better confirmed objective response rate, and finally also final data in improvement in progression-free survival and overall survival. An important analysis has been done when we consider overall survival specifically in patients with brain mets, and those data have been published in the Journal of Clinical Oncology. Again, tucatinib, trastuzumab, and capecitabine may provide an overall survival benefit in both patients with stable and active brain mets. Here we have the data in active brain mets. And here we have the data in stable brain mets. What about other agents when we consider, of course, the activity in brain mets? The Camilla study, the final update was published on the Annals of Oncology in 2020, still had the potential of a response in patients with brain mets. In the Camilla study, the objective response rate overall was 21%. And looking at the outcome, even if it was not so good like in tucatinib, trastuzumab, and capecitabine, we have 18 months of median overall survival in brain mets at baseline versus 30 months in no brain mets at baseline. So it's an important observation, this one. Another agent that has been developed in HER2-positive disease was neratinib. Neratinib was explored in the context of the NARA trial, prospective randomized trial comparing neratinib plus capecitabine versus lapatinib capecitabine, and neratinib improved the median progression-free survival by 2.2 months with no overall survival benefit. It's an approved agent, at least by FDA. Of course, we should consider toxicity and safety issue. Don't forget that in the past, if you remember, Fabrice André published this study exploring the potential of combining trastuzumab vedotin or paclitaxel plus or minus everolimus. And also there was an improvement in progression-free survival. So, which questions do we have, of course, in HER2-positive disease? I believe the primary question is, can we eliminate chemotherapy in HR-positive disease? In my opinion, this is a very important question that should be addressed. So the clinical trials evaluating endocrine therapy plus HER2 therapy in HR-positive disease are the following trials. There is the tandem trial, trastuzumab plus anastrozole versus anastrozole, lapatinib plus letrozole versus letrozole, the Electra trial, trastuzumab letrozole versus letrozole, the Pertain trial, in which we have the clear demonstration that as a maintenance treatment, we have finally the opportunity to explore these, and then the alternative trial. Don't forget that we have another maintenance treatment that is combining endocrine therapy, trastuzumab, and palbociclib, but they are all trials exploring the maintenance treatment. The only trial that evaluated endocrine therapy plus HER2 therapy versus chemotherapy plus trastuzumab was the CISUC trial. The CISUC trial was presented during the ASCO meeting. Is a trial that has been conducted only in China. Prospective randomized trial comparing trastuzumab plus endocrine therapy versus chemotherapy plus trastuzumab is underpowered, of course. 28% of patients included were de novo, 80% ER positive, 70% with less than 2 sites of disease. But in this study, there was no difference between endocrine therapy plus trastuzumab versus chemotherapy trastuzumab. So in conclusion, we have many, many new treatment options in HER2-positive disease. The first-line therapy is still Cleopatra, in which there is an overall survival benefit. In the second-line setting, in my opinion, the optimal treatment should be trastuzumab deruxtecan. But we can use tucatinib, trastuzumab, capecitabine in active brain mets. And we have exactly the same options also in the third-line setting. Many other targets with a new mechanism of action are being evaluated, including the PI3 kinase inhibitors. There is the EPIC trial evaluating exactly alpelisib plus trastuzumab in the third-line setting. We have HER3 agents. We have new generation of antibody drug conjugated. We have bispecific antibodies. But the most important question, I believe, that we should address in our discussion is I really believe that now we have the opportunity to cure HER2-positive advanced breast cancer. That I believe you would agree with me that specific patients with maybe the novel metastatic disease and with oligometastatic disease, with all these new therapeutic opportunities, maybe can be cured when they are metastatic. So thank you very much indeed, and I would be very happy to take questions.